This next panel is definitely going to excite you all in many ways, especially ones that you never saw coming. This panel performs healthcare in the most extreme, unforgiving, and extraordinary environments imaginable. Our 4 awe-inspiring panelists are going to take you where the limits of healthcare are pushed farther than ever before. Our moderator, Mary Showstark. Mary, come on up. She's one of the most amazing people that I know, and she embodies versatility and ingenuity. She drives progress in global health, education, and space health. And with her exceptional ability to connect ideas and people, she transforms initiatives, whether large-scale or informal, into impactful advancements. She's a physician associate and assistant professor at Yale University and affiliate faculty of the Yale Institute of Global Health. She seamlessly combines academic excellence with hands-on expertise. And her dedication to strengthening healthcare on a global scale, it's showcased through her pivotal role as Chief Liaison Officer of Health Tech Without Borders. She has a PhD in Security and Intelligence Studies, and that's from the University of Buckingham, and she serves as a World Bank consultant specializing in disaster health and climate. So I leave you in great hands with Mary Showstark and this amazing panel.
All right, well, thank you. I'm going to bring all of our panelists on stage. So I'm going to call Dr. Glenn Barnes.
Howdy.
Oh. Glenn always surprises me. Dr. Stuart Harris. Dr. Diana Monroy. And Starr Schroeder. You can sit anywhere, obviously. Oh, okay. All right, you're welcome to sit. I'm going to introduce them and their bio, so feel free to sit. You want to sit? Yeah. No chair. Okay. All righty. Well, so I'm going to start off with Dr. Glenn Barnes' bio here. Dr. Glenn Barnes is a visionary leader in austere nursing, combining over 30 years of global experience with the utmost reliance and expertise. He's a former U.S. Army Green Beret, and his groundbreaking work has shaped the field, creating innovative courses that prepare nurses to deliver exceptional care in the most extreme and unforgiving environments. At Texas A&M University, Dr. Barnes serves as a clinical associate professor and coordinator of the Aerospace and Extreme Nursing program. This pioneering program is redefining the boundaries of healthcare, equipping nurses with the skills to navigate challenges in remote, resource-limited settings like space habitats, polar regions, and disaster zones. By merging advanced training, innovation, and the indomitable spirit of exploration, Dr. Barnes is shaping the next generation of nurses who will boldly push the limits of human capacity and compassion in the most extraordinary circumstances. Now you can say howdy.
Howdy.
All right, Dr. Stuart Harris embodies the spirit of a Renaissance man, shaping the future of medicine in harsh and extraordinary environments. As the founding chief of Massachusetts General Hospital Spear Medicine Division and director both of the MGH Wilderness Medicine Fellowship and Space Medicine Fellowship, his groundbreaking work bridges space, ecology, and resource-limited care. As an associate professor at Harvard School, Dr. Harris seamlessly merges academic excellence with hands-on expertise. His pioneering research spans acute altitude physiology and the innovative use of ultrasound in extreme terrains, from Everest to Kilimanjaro. Editor-in-chief of Auerbach's Wilderness Medicine, Dr. Harris's influence reaches across disciplines. A former firefighter, EMT, and founding member of Space Medicine Fellowship Council, he chairs the National Outdoor Leadership School Board. We have Diana Monroy next, who is, there you are, a dynamic aerospace medicine specialist from Colombia, whose work spans military and aviation medicine, occupational health, and cutting-edge research. During her residency, she participated in international collaborations with the FAA and the Colombian Civil Aviation Authority, producing impactful publications and technical reports. Her military experience as an Army officer includes psychophysical aptitude evaluations for aviation personnel and expertise in extreme and operational medicine. In the realm of civil aviation, Dr. Monroy has overseen aeromedical certification processes, air ambulance surveillance, and regulatory documentation, and sector-specific health recommendations. Dr. Monroy's versatility extends beyond aviation. She specializes in fatigue risk management consulting for industries like oil, mining, and a variety of other transportation modalities. Her dedication to education and research is evident in her work on aeromedical transfer, flight physiology, sleep and fatigue, and extreme environments. Currently, she is advancing the field with groundbreaking project on dentistry in extreme conditions. Her multifaceted career showcases a rare blend of expertise, innovation, and commitment to improving health and performance in diverse, challenging settings. And next we have Starr Schroeder, is an innovator in the field of space medicine, blending an extensive background in critical care, emergency nursing research, education, and management with a deep passion for advancing nursing's role in space exploration. Her contributions have earned her recognition on the global stage, including presenting medical guidelines for commercial spaceflight, a review, at the International Astronautical Congress in 2019, and the ins and outs of space nutrition during the Association of Spaceflight Professionals 2020 Space 101 lecture series. As a valued member of the Aerospace Medical Association, National Space Society, and Wilderness Medical Society, Starr actively bridges clinical expertise with the expanding frontiers of aerospace medicine. Anticipating her master's in human factors in aerospace from Embry-Riddle Aeronautical University this May, she has already authored critical works on spaceflight nutrition, spacesuit trends, the lunar environment, and the pivotal position paper on telemedicine during the pandemic. Beyond her scholarly achievements, Starr collaborates on groundbreaking research, including ECG studies and parabolic flight and spacesuit life support testing with Final Frontier Design. I welcome you to give our panelists a round of applause because those bios are amazing. So thank you all, and they are all my fellow wilderness medicine. So a lot of us have met here for the very first time, but have been collaborating for many years together. So we do host a Wild Med. I'll do a little plug for Wild Med Wednesday. We do host a speaker series that's free to everybody, and you can learn about austere medicine, wilderness medicine. It's the first Wednesday of the month. If you Google Wild Med Wednesday, it'll pop up. You can register for the Zoom meetings. But we've had some of them as our wonderful speakers, and soon, Starr, you can be another speaker too. So it is a real pleasure and honor to have them here in our Health Tech Without Borders family here as well. So I want to start off with question number one, which is really just, I want you all to take about 3 minutes to introduce yourselves. And so Starr, let's start off with you.
Hi, I'm very happy and excited to be here. As Mary said, my name is Starr Schroeder. I've been a nurse for about 25 years. Most of my experience has been in the ICU and emergency medicine. I always dreamed of a career in aerospace when I was growing up, but I hate math. So my grandma told me that I would need to do a lot of math, and I was like, oh, I'm out. But I've conquered that fear in my later years and gone on to achieve a master's in human factors, which when that came up, I was doing bioastronautics work, and I had done research on normal people who aren't trained, who haven't had extensive physical, mental training, flying to space, because we're starting to see that, right, with tourism, and we're thinking of taking longer trips. And we're really going to have to sort out what that looks like in terms of training and how our body handles that, the physiology, the psychology, the cognitive resources that we have within ourselves. And when I learned about human factors in aerospace, I really thought that was a unique position, that I was in a unique position to sort of pivot my career and learn more. It kind of expanded on what I already knew. I already had the foundations of the physiology. I already knew psychology. I already knew cognitive processes, but studying the limitations and how those affect us and what we need and how to mitigate those effects as we travel further in space became very important to me. So my research for my master's degree has focused a lot around innovative technologies, developing technologies, and how those can help us with our psychological welfare, our psychology and our cognitive functioning, and how we can use those products to assist us when we're far from other communication, when we're far from each other, when we're isolated together. How can those things help us cope and maintain our mental health and our cognitive abilities to function so that we can travel safely and that we can stay healthy as we are leaving Earth? And so that has been my work, and I'm excited to continue traveling down that road.
Amazing. And I think a lot of that can be transferred here to Earth
Absolutely.
and space.
Absolutely. And I will touch on that later,
Yeah,
but there are some things in that research that are very pertinent, yeah.
All right, Glenn.
Well, after that introduction you gave me, I don't know what else to say except I'm a Scorpio. I enjoy long walks on the beach. I have a deep passion for providing compassionate, competent care anywhere on the world, under the world, and now off world. So I think that is, as healthcare providers, no matter what level you're at, that is our goal. Our goal is to provide competent, compassionate care to those in need, point blank. And we can focus on ourselves all day long, but when you come down to it, we should focus on our patients, those who need us. Outside of that, fun fact, I used to collect comic books, so I know that's a
And I think you're a fantastic educator and teacher as well.
Yeah.
So
well, yeah, there's all that.
Of course. All right, Stuart.
Hello all, I really appreciate the invitation, Kendra, and the community. Fairly humbled to be here. The kind of guiding precept of my career as I'm looking at it in retrospect, I started off as a whitewater boater, a mountaineer, very deeply interested in medicine and patient care. As Glenn has said, it all comes down to what happens at the bedside, and the bedside might be on a glacier on Denali at 14,000 feet, it may be on the sides of Everest, it may be along the shores of northern Japan after the tsunami. Billy's story there struck fairly close to home. But that sense of how do we best provide care wherever you are on the globe are now increasingly off the globe. So human-based care is a responsibility for anybody in our profession. And so wilderness medicine for me, as I've gotten more and more involved, started a fellowship, editing the textbook I think this is the first public announcement of it, but so Auerbach's Wilderness Medicine is a 2,600-page Bible of wilderness medicine, and the subtext for the 8th edition that we're working on right now is going to be resource-limited medicine under austere conditions. Wilderness medicine, it's terrible nomenclature. Nobody knows what in the hell it means. Everybody brings something to it, which is great and lovely. But resource-limited medicine under austere conditions defines where our expertise is most useful, and that can be, again, under hypoxic conditions at altitude. It can be in northwestern Japan, where we have an active program with native Alaskans. It can be in the lab, looking at how mitochondria respond to low oxygen states. But ultimately, it's trying to teach young doctors, nurses, PAs, how do you best care for that patient in front of you? And for me, wilderness medicine isn't a specialty that's 40 years old, thereabouts. When Paul Auerbach wrote the first text, it's 2,400 years old at least, when a guy sat down outside under a tree with a patient, used their brain, used their physical exam skills, and cared for that human being in front of them. And that obviously was Hippocrates in the West, and it's happened in other iterations widely. But that's what we learn outside has great application to, if you're in a tertiary care center in the ICU and the ED, that ability to make eye contact, to listen to the human being in front of you, to use a diagnostic engine of narrative. That's how we figure out the world, is storytelling, and I think Billy did a beautiful job on that as well. That can improve care, provide more cost-efficient care, safer care, and ultimately much more effective care, and that's kind of where I see us heading.
I love it. Thank you so much. And I think, physical exam skills, everybody in this audience, I know you're medical, don't forget those skills. They're so important in the austere environment and rural environment. And I teach my students that all the time. All right, Diana.
Okay, thank you for the invitation. I'm Diana Monroy. I'm from Colombia. So English is not my native language, as you can see. My story is, I'm a medical doctor. I work in Colombia. In Colombia, when we finish our medical school, we have to do a social service year that is working in rural areas in Colombia. And when you are in medical school, at least in Colombia, you learn about medicine in books. And you have a lot of guides. You can see the medical evidence from another countries and other big organizations. But when you are in your first year as a medical doctor in a Colombian town, you don't have all the resources that you can learn in the medical school. And that was my first encounter with the wild medicine, because that was pretty wild. I had to work in very limited resources places, and I learned that I need to be creative sometimes, and we need some skills besides the knowledge that we can get in books. My life had taken me into the military, and in the military field, I had the opportunity to know about the aviation. I worked with the military aviation in Colombia, in the Army, and when you see that is a really changing mind field, because you see the things in a different way. Regular doctors see people who are sick. We don't see people sick. We see normal people. But the focus with these cases is pretty different, and we must be alert of what kind of things we are going to search in every individual. When I had the opportunity to study aerospace medicine in Colombia, I went to discovery from the extreme medicine. The rest of the world talks about extreme medicine, but I have already worked in extreme medicine without knowing this is an entire field. So when I discovered that, I thought that, okay, we are working in Colombia in these conditions for many, many years. We have some practices. We are developing some things that can help people, but we are not doing this in an evidence-based way. So that's one of the things that came me to the university to try to get the dentistry extreme program, because in all the fields in medicine, we have a lack of evidence in aerospace medicine and extreme environments, but dentistry is one of those that we cannot find anything. And it's important to at least begin and to do some mental awareness in our health providers to know that we can do these things, but in an evidence-based manner.
Thank you. And improvisation. How many people here have improvised in their job in some kind of way in the field? We always try to do what's right for patients, right? But there's a lot of times where we have to use limited resources. All right, so moving on to our questions here. I'm going to direct this question to Glenn and Diana. Many of the Space Health Nexus audience works in community health and resource limited or rural settings. What lessons or tools from your research could redefine healthcare delivery in these earthbound communities?
Okay.
I know you touched upon that, Diana. You want to go ahead?
Thank you. Thank you. I think that one of the lessons that I learned is that you need to be able to communicate with your community. You know, in medical school, we learn a lot of words that are pretty rare words. And you need to know your community. You need to work. You need to be able to communicate that they are going to do in their life. Another thing is that you must have to interact with another health professionals. Yes, I always say that then a nurse is the right hand of a doctor. Without nurses, we are nothing. Yes, we are a perfect complement. Thank you. You are a perfect complement for us because you are more called, and I don't know if it's part of your formation and as a nurses, but you are more connected with communities than us, and it's important that relationship and the relationship with another professions like, I don't know, dentistry or laboratory or something like that. Because if you're not integrated with this team, you are not to do a better work. And in extreme environments, in places where you have a limited resources, you need to be a strong equipment. And you never know how another person can manage some case. And when we are facing one case in different ways to see, we can find creative ways to treat them.
Absolutely, that collaborative care. Interprofessional education is what I always teach my students. When you go out into the field, all of you, I know we know our professions, we all have egos in some capacity. We're like, oh, I can solve this problem, I can fix this. But introduce yourselves to the other people, find out their names, who they are, and what they can help to contribute, because then it makes you stronger and you can work together. So, Glenn, any other words on this?
I mean, just to kind of tie in with that, when we're talking community and community development, we're really looking at building resilience. And the best way to do that is more grassroots efforts and getting in, and because what is a community? A group of people. And if you want to build community resilience, you have to start with the individuals. So it's kind of a bullseye effect. You have to take care of the individual, then the family, then the community, and start expanding outward. So that means that we do have to work together, and we need to make sure that all of our interprofessional work is distributed and that we're leveraging technology so that we can maximize, especially in resource limited, we can offset the lack of personnel with technology. And that way we're not replacing people, we're just amplifying the people with the tech. And I think that's where we really make our money.
Yeah, everyone's needed. There's a nonprofit called Third Wave Volunteers, and their slogan is everyone's needed. And there's times where I've deployed with them in NGOs, and there's people who work in trees, and I'm like, what is somebody with trees doing here? You know, and they're cutting down the trees. They understand which plants need to be there for the ecosystem. So that collaborative effort is really, really amazing and important. Thank you for that. So moving on to our next question, funding and workforce shortages are commonplace for first responders and healthcare in general. In what ways can your care model be scaled for communities facing resource limitations on Earth? And I'm going to direct that to Glenn and Stuart.
Okay. So when we're looking at money, everybody gets greedy about it. And it's really hard for people to give up that money. So we have to figure out, one, where can we get the biggest bang for our buck? And then how can we distribute? And again, I feel like that is getting it down to that grassroots effort and using your force multipliers by, you know, you have your physicians and your nurses and then your first responders, but we also have the civilians, the people themselves. We teach them stop the bleed. We teach them CPR. We teach them things that build their individual resilience. And so they don't have to rely on a licensed professional when they have skilled people that can help out. And I think that we're going to have to be more creative because as a paradigm, we as humans are really silly in the fact that we'll spend more for actors and athletes than we do for healthcare and education. And as long as we set that paradigm, we're always going to be behind the power curve on that. So we have to be smarter with our money. We have to figure out how to use force multipliers and we have to look at how can we use tech to amplify the human effect.
Absolutely. And funding, we know there's lots of budget cuts, we know there's lots of things, but we know there's lots of ways to improvise and still do things and still do the best things for our patients. I think what you say along the lines of community is super, super powerful and important. And I think one of the things that I know, one of the things we do at the World Bank is we always engage community stakeholders in building the emergency operations centers in different countries and really having the voice of the community to say, hey, what's happening here? So Stuart.
Yeah, following up on Glenn's thoughts, and if anything, nurses as the right hand of the doctor. I think they're usually the brain of the doctor, if you're a good doctor at all. The number of times my bacon's been pulled out of the fire by listening to my nurses is huge. So I'd put them at the head, not at the hand. But my sense that a huge portion of my career and my work has been being curious in places where there isn't funding. And so figuring out how to motivate people, build teams, succeed in your mission without counting on funding has opened up a tremendous amount of opportunities for us. So rather than looking at, what's the NIH funding or ARPA or wherever else is being funded this week, if you can find your passion, your curiosity, develop a team around that, sooner or later, the rest of the world catches up and will be willing to fund you. So I think that's, if you take anything away from whatever I say, I think that's it. Find your passion and run with it. The world that we've kind of built is, as far as helping people in fairly resource-limited conditions, that can be, again, in wilderness areas, but it can be the work we're doing with Alaska Natives in Kotzebue with Menilik and others. We've developed a joint program that Alaska Natives and colleagues in Kotzebue up in the far northwest of Alaska, north of the Arctic Circle, and Mass General, where I am, trying to leverage the talents and technologies of a major academic medical center like we have and applying them there. And there's no reason, I thought it was a little curious that we're on the NASA campus and we're using Starlink to communicate. So there isn't anywhere on the planet you cannot communicate very effectively and with fairly broad bandwidth these days. And so your ability to get expertise anywhere on the planet, it's a fantastic time. Just the walls that are falling down, distances evaporating, and the ways that we can interconnect people who even 5 years ago would have been kind of sidelined just because they weren't part of the immediate team. The amount of work we're getting done on Zooms and other electronic media that are hugely impactful and have global reach and direct patient care applications. I mean, it's a cool time to do what we are doing. It's a little terrifying in some ways if you look at stasis as, where you want to be. Stasis is gone. We're changing and rapidly so, but that gives us an opportunity to make better healthcare, better decisions, more equitable in outreach, and just helping to get the resources to where people are in need rather than saying, we talk about thinking outside the box. For me, the box is a hospital. That's where, the death of, imagination. If you can't think beyond the hospital walls, something is wrong with you. But that's where we are. And I think that sense of how do we get care to wherever that patient is in need, that's our job. And that's fun. I mean, that's exciting. And everything we do ought to be both of those things.
And I think as tech gets cheaper, it gets more distributed. So we're bounding and we're breaching those boundaries more and more just as those costs come down.
And okay, sorry.
Yeah, I think I echo what he says, what Glenn says. I think cost is a very big factor, and I think as those things come down and become what we are used to paying for technology, I think that we'll be able to reach a lot more people.
Absolutely. And go ahead, Stuart.
Well, no, I was just going to say, just personal experience. So a large part of my career has been looking at extreme environments and how in human health is an ecological phenomenon. We are created and exist because of this extraordinarily narrow kind of subset of conditions, environmental conditions, that we just take for granted. Oh, you got 21% oxygen and 760 millibars of pressure. Oh, we got gravity, on down the list. But we are selected for that extraordinarily narrow bounds. And so by going outside of that, and that's why altitude is so interesting to me, to figure out how that universal life threat of hypoxia which people ask me and say, Stuart, you're in sea level Boston, why do you care about high altitude illness? Because that's what a heart attack is. Just lack of oxygen available to the heart. That's what a stroke is, lack of available oxygen to the brain. That's what somebody who gets multiple gunshot wounds, that's lack of oxygen delivered to the tissues broadly. So what we can learn in extreme environments has direct application everywhere in the world. And so a large part of my career early on was trying to study high altitude illness for that reason, and I found I didn't have the tools I needed just to be able to address some of the questions I had. And so talking about technology and our ability to get it out, this was in the early days when ultrasounds were very expensive, very fragile, required pretty careful care to begin to survive. And I said, you know, why can't we study the changes in the lung and the brain with ultrasound in the Everest area? And people said, you're crazy, you can't do that, you know, for all the reasons, you know, there's nowhere to plug it in, blah, blah, blah. And I had an extraordinary fellow who's like, I can do this. And he established essentially, you know, the use of point of care ultrasound in remote and austere conditions, which now is just like, anybody who's a care provider trained in the last 5 or 6 years would be like, no poop, that is just so obvious. And now we've got devices rather than $40,000 and heavy as stink. You know, you can plug them into your iPhone for $1,200 and get beautiful quality images, and you can upload them and have them reviewed by somebody, you know, in my office in Boston, wherever you are on the planet. And so that ability to see changes in our ability to forward project diagnostic testing, I mean, things are just, and that's easy, and some really cool stuff. And as we look at, you know, long-term space missions and going to Mars and other things, it's like that model kind of falls apart because of the latency in communication. But with AI and other changes, you know, we're addressing that. So it's a cool time.
Absolutely. I think you've all demonstrated that we're very interconnected. We have a lot of increases in technology, and we can, you know, with Health Tech Without Borders, we see people in the Philippines, and we do telemedicine clinics, and they're connecting back to experts at Harvard and having these conversations. So this network, and like I mentioned, and you talked about, you know, volunteer and find your passion. And I know I volunteer for Health Tech Without Borders. Every one of the disasters I've ever been to, I volunteered. The organizations a lot of times will pay the trip coverage over there. I'm not independently wealthy. I've followed my passion, and somehow it's just made it work. But do it and try to reach out, create these networks in these different groups, because we are interconnected and we can all help each other. So moving on, let's talk about, what about home health? Can any of your models help those who are aging in place or need to receive healthcare in their homes? I'm going to focus that to Starr and Diana.
So my work in space health and space medicine has been around the fact that we're going to be far away from Earth. So we're talking about these things, as Stuart said, you know, you can receive healthcare anywhere in the world, just by electronic communication. That's going to be very limited as we move further away from Earth and space travel. And so you can draw a lot of parallels to that, especially in this crowd who are working in resource-limited areas. We have to think about the confinement and the isolation, and a lot of our aging population face that, right? So when we think about technologies that can help, we're going to have to think about technologies, as Stuart mentioned, like AI, virtual reality, those kinds of things, to help us with our cognitive assistance when we're far away from Earth and we can't communicate with each other. You know, Glenn's here on Earth, I'm flying to Mars, and I have a question that I need help with. He's going to be probably a good 20-minute communication lag from me. So we're going to need those resources that can help us treat our patients, care for our patients. And the other thing about it is that a lot of it is preventative. We don't want to be sick when we're far away from Earth. So if we can apply those technologies to our aging population who are isolated, who are confined, who you know, need that health care to be preventative, then those things can really, I think, help us move along. And once we start using those things more widely, I think that they will become more accessible. And that is going to be huge, I believe, for people who are in rural environments, who can't travel to the doctor, who are far away from the specialties that they need. Maintaining their health without having to interact all the time for sick visits and those kinds of things, being able to help them maintain their health through emerging technology as nursing professionals, as healthcare professionals, is going to be huge. And those are strong parallels that we can draw as we travel further away from Earth. We're going to need those technologies, and that's a perfect example of how we can use that here on Earth.
Absolutely, and I think we heard an excellent presentation yesterday by Isabel, I think it was, on the remote technology and remote sensors and all of that, so it's amazing. Diana.
Yes, in my experience as a military doctor, I had one of my biggest concerns about how to provide a good first aid care for my soldiers in the battlefield. Because they were just soldiers, they don't have any health or medical background, they are just soldiers, very good soldiers. But when we have some patients there, our conditions were so difficult to bring them to appropriate facility care. So I learned that I need to be careful with the knowledge that I teach to my soldiers who are in the first aid field. They need to learn how to give a basic and a primary care for those soldiers. And I learned that me, as a doctor, need to learn how to use some communication devices, like radios, because we don't know how to use them. You don't have a special communication, training in the medical school. You are just going to learn medicine. But for the first time you have to talk in a radio, it's crazy because you don't have which button you need to push. And you see that it's difficult to people who are not in healthcare to talk with you. They don't know how to express what they sing. So they are like, oh my God, he is bleeding. But where? And is bleeding from a scratch, or is just a bullet in his side, his body, or something like that? So it's important that we can take advantage of what we can teach to people who are not from a background of healthcare. They are pretty useful. They are in the front line. They are with people. So this is one of the strategies that we can use with the elderly and the aging people. They are usually with caregivers that are families or people who are just taking care of them, and we can give them some kind of training in basic tools, and it can save lives.
Yeah, the intercollaborative approach. That's what I did my PhD on with security intelligence students, and AI and cyber, and how do you work together with healthcare professionals to manage a disaster or wicked problems, such as human trafficking, climate change, all of that. So, Glenn, I know you had a comment and Starr.
Well, I had a just beautiful thought, and she stole it at those last two sentences. Because when you think about it, you go to the austere locations and remote locations, they already do home health because they're being taken care of by their families. It may just not be effective. That's where we can come in and bring our knowledge and our skills and do that through telemedicine or those force multipliers that we talk about. People that are trained, that are language capable to go out into those areas and teach the families how to do better care.
When we think about isolation as well and confinement, we have to think about mental health, and that is one of the biggest challenges, not the biggest, but one of the biggest challenges as we move further away from Earth. And if we think about our aging population, we do see a lot of mental health challenges in our aging population, a lot of behavioral health things. And you know, if you think about it, they're cut off from a lot of resources a lot of times in terms of they've lost a lot of family. They've lost a lot of mobility. If you think about when you're having a bad day, how nice it is to just go outside and take a deep breath of fresh air and just get a little bit of sunlight or rain or whatever it is that's happening outside on your face. You know, we're so used to all of our senses on Earth. And, you know, as we travel, our senses are going to be altered. The things that we have access to are going to be altered. And so those are the things that we're going to really have to try to focus on to maintain that health as we travel further away from Earth. And that is something that I think that the elderly or aging population can really benefit from as well, maintaining that mental health. How do we restore those connections? How do we use technology to restore those connections that we've lost in terms of our senses? And I think we have a huge opportunity to do that.
I'm interested in where BCI and brain-computer interfaces are going to be, because are you going to be able to talk to Glenn and Mars when you're off to another mission, or is somebody in their remote home and alone going to be able to say, somebody's going to hear, oh, they're potentially suicidal or alone? So it'll be interesting where technology takes us in that. Stuart, did you have anything to add to this?
Yeah, I was just thinking, again, just to present the opportunity, things are changing and a little scary, but I was working a shift, I guess not last night, night before last, and over the weekend, in that sense of how do we expand the options for care outside the hospital. So hospitals are potentially dangerous, you know, sources of infection and other things that we've got an increasingly well-developed home hospital where people who are actually really sick might need IV antibiotics, might need some attentive care. But if we can have that occur in their homes, where they're getting good care, they're being monitored, you know, I as a patient, I sure as hell would rather be in my own home, in my own bed, if at all possible, than be admitted to the hospital with the impacts on sleep and everything else that occurs with that. So a lot of this work is directly applicable in each of our individual communities. And as somebody who's at some point going to need it, the option of having distributed care under what have been traditionally very resource-limited conditions, it's actually better care.
Yeah. And I had a conversation this morning, actually, and we were talking about freestanding emergency departments and how these are being built and all over, and you know, they think it's helpful, and I always thought, oh, well, this is helpful. But then with the conversation switching that where you have to, those patients need to be admitted somewhere, and then there's nowhere to admit them, and then that's putting more strain on the hospital, and then it's also putting strain on the ambulances and the systems, and I thought, whoa. So I thank you for that conversation this morning. And so I thought, I had never thought of that, you know? So it's that conversation across the different sectors and building and workforce and all of that. So it's super interesting what we can learn from talking to each other. Next question. So if advancements in care models are not achieved, what are the potential risks or challenges of space travel? What are the risks and challenges for earthbound community care? And I think you all touched upon this, but we'll start with Stuart, Starr, and Diana, and then Glenn, of course, you can add. Starr?
Sure. So our care models right now are very well developed in terms of nurses, doctors, PAs, nurse practitioners. The system is developed, right? Right now, the space care industry uses primarily physicians. They do use nurses, but not necessarily on mission or mission return. And so as we go forward, as we move further away, you know, we really can't, let's say, establish ourselves on Mars without a system that mirrors what we have here. We cannot just send doctors, because we've talked about how nurses are kind of the glue sometimes that hold things together, and not just nurses, but everyone in the healthcare industry. We are all collaborative. It is multidisciplinary, and it has to be to function, because I don't have the same skills that Mary has. I don't even have the same skills that Glenn has, and we're both nurses. I don't have the same skills, as a doctor or physical therapist, and on, right? So we all have to work together, and we are, if we don't develop that into a space health care model that mirrors what we have here, it's going to be very difficult to function and maintain and take care of our patients. It's going to be very difficult. There's no way if we have people on Mars and a doctor there that nurses or physical therapists or physician's assistants are going to be able to stay here on Earth and help care for those patients. There just isn't any way. So we will have to, things will have to develop to mirror a little bit more what we have going on here, yeah.
And I thank you for bringing up PAs. I'm a physician assistant, physician associate, and we have, thank you. We exist in over 80 countries under 35 different titles, and I do a lot of that global healthcare workforce as well. And we're not trying to take over the job as a doctor. Nurse practitioners, doctorates of nurse practitioners, we're not trying to take over the jobs. We're there to be part of the collaborative workforce. All right, thank you for that.
I'm a huge supporter of our PAs, so thank you. I think a large part of my work in the last 5 years has been looking at, and this has been dogged residents and fellows and people from around the country reaching out and saying, Stuart, this is wilderness medicine. Space medicine is wilderness medicine. I'm like, oh, no, it's not. I don't need anything else to do. But ultimately, the sense of NASA and other governmental, the only people who've been flying people in space have been governments up until fairly recently, have an impeccable system of preventive medicine. So it's a preventive medicine board called Aerospace Medicine, with the whole idea being you want the very healthiest human being you can to go up into space. You want the right stuff, and that's a great way to mitigate risk. And it's hugely effective. I joke, but it's true. If you have the choice between an airbag and a world-class trauma surgeon, take the airbag. And NASA has used that system beautifully. But as we start going from a very small number of extraordinarily healthy human beings who have largely been almost exclusively, other than Apollo, in low Earth orbit, so bad things happen, you can come home, we need to start thinking about, okay, you've got much bigger populations, from 18-year-old to 90-plus-year-old William Shatner blasting off into space, and suddenly you're not 4 hours or 2 hours from coming home if something bad happens, you're days or months from coming home. So our space medicine fellowship and working with colleagues around the country and with the commercial space industry and NASA is looking at how do we develop the ability to diagnose and treat people wherever they are. So we ought to be able to do that just as we've applied in terrestrial low resource environments. How do we do that? If you're on the way to Mars and you get sick, that's a bad day for you. And how do we intervene, one, to prevent it, but then to treat people where they are?
Well, I'm an Aries, so Mars is my ruling planet, so I hope it would know, but maybe not. Diana.
Okay, so we have developed as humans many technologies in the medicine field to provide healthcare. And we are pretty good now. As you said, we can have an ultrasound in our pocket. It's not science fiction, it's real. But if we don't continue to developing in this field, it could be a big trouble for people, and it's people in space and people on Earth. With time, when you are treating persons in your medical practice, you see that people are having different needs in different scenarios and in different ages. And now we are facing, for example, the opportunity to have a tourist travel to the space. in past times, you don't think it can be possible. Now you just have to have enough money to buy a seat in one of those programs. So we are seeing people who are old, like 90 years old, who are traveling to space. And when you are 90 years old, you are probably have at least 2 conditions, medical conditions, yes? So, and these medical conditions are going to need to be treated, and you don't know how to treat them on space. Our space travels are during longer in the time, and we are now dreaming to live outside our world. And people are people, and people get sick. Even with all the preventive medicine that we can practice with them, even with all the resources that we can put in a space station, people are people, and people are getting sick. So we need to move forward to look what are the best solutions for these people. And another thing is not just only for the space, because on Earth we are facing that phenomenon that we are getting a lot of people who are aging, and there are not enough people who are born. So in the future, we are going to have many, many elderly people, and we are not having people who are taking care of them. So that's a big trouble, a world big trouble.
Big. I love how you talked about the space tourism and travel and all of that. I mean, I used to live on Maui, and so people would always come there to travel and be tourists and ride down the volcano and at top speed, and they'd always get into a bike accident and end up in the center of the hospital, and they say, well, I've never rode a bike before. I'm like, why do you come to ride a bike here? And like, you never rode a bike. So the space tourism is going to present a lot of different challenges, especially with age and all of that. When you talked about technology being in different locations, I think that's super valuable, because just call technology companies. Just like I didn't realize that about a standing ER causes all of that backup. You never know like what people don't know. Like when Butterfly, the handheld electronics, we called them for some remote group that wanted to collaborate, and they were like, oh, cool, sure, here, we'll donate some butterflies. You never know. Health Tech Without Borders, we have tons of contacts there. So I think all of that's important. I know we have 2 more questions here. Glenn, did you have something to add?
No, I just think that we're going to see things change in response to how the future actually unfolds. Right now, or even with the space tourism, it's an up and down.
Yeah.
And so we can still manage that with concierge medicine, which is basically what we're facing now. But we're going to have to transition to a more primary care healthcare model if we extend those periods. And that could extend with different types of space tourism, or if we're going to build a moon base to launch to Mars. Now you've got construction and you've got infrastructure building, and you're going to have 3 to 6 month rotations to be cost effective and not put people at harm's way for the low gravity issues. Yeah. So when you do that, then you're going to have to move to a more traditional primary care model, because you want me as a nurse, you don't want me as your physical or respiratory therapist.
Right, absolutely. Good. So in our last question, let's have you answer this in maybe 1 or 2 words here. What does success look like in your field over the next decade, and how could these advancements shape the way we approach healthcare for both space exploration and earthbound settings? Like, what's the 1 word or 2 words that come to your mind? Starr?
More participation, more nursing professionals getting into the field. I know that a lot of people think there's not a way forward, but we need to create that way forward.
Absolutely. Thank you. Glenn?
I'd say long-term habitation, both on space station and moon bases.
Amazing. Stuart?
To have health recognized as an ecological phenomenon, so just if we go to space, 99.x% of our healthcare budget is simply recreating in space what we completely take for granted on Earth, attribute no economic value to. It's just bizarre. I think we sometimes get confused by the metaphor of the Garden of Eden. We're in the garden still. And to go away and to have the overview effect looking back and realizing how good we have it and maybe make a little more thoughtful decisions would be ideal.
Thank you. Diana?
I think in 3 words: resilience, adaptation, and learn.
Yes.
We need systems that are adaptive for our changing world. We as a healthcare professionals, we must learn not only about healthcare, we need to learn about many other technologies that we are developing as humanity.
Amazing, and maybe we can learn from nature as well, too, and our other colleagues and peers here. Thank you so much for your time. Thank you to our amazing panelists, and thank you, Comet and Kendra, for this panel. Thank you.
Amazing panel. Thank you all so much for coming and presenting. Oh, we'll do a picture in a little bit. But it's now time to go from filling our heads to filling our stomachs. Lunch is served right behind us. So please go through, grab your meals, and then come back to enjoy it in this room in great company.